like to talk about is focused on tissue extraction during minimally invasive gynecologic surgery. We are very fortunate to have outstanding leaders in gynecologic surgery share their expertise with us in a roundtable discussion of their approach to tissue extraction. Among these national and international leaders were Arnie Advincula, Linda Bradley, Sherelle Iglesia, Kimberly Coe, and Jason Wright. From my perspective, this article reinforces the need to continue to use vaginal hysterectomy with intact removal of the uterus in all cases where that operative approach is optimal for the patient. Vaginal hysterectomy is strongly supported by evidence-based publications and is supported by our college. The next most important point, I think, made by the experts is that we are in a time of great transition because of the increasing realization that some large uterine tumors that are being removed with morcellation contain occult cancers. And there are some retrospective series indicating that this may occur in as many as 1 in 350 cases of uterine tumor surgery. The experts and I are awaiting the final decision and guidance of the FDA concerning power morcellation. But in the meantime, I think we have two general issues facing us. One is, can we remove uterine tumors intact? Or, if we are going to disrupt the tumor, should we first contain the tumor in a device such as a containment bag prior to disrupting the tumor through morcellation or coring? This issue, I think, will continue to evolve, and my prediction is that in the future, we will be taking out uterine tumors either intact through an incision sufficiently large to remove the tumor without any disruption of its cavity, or we will be placing the tumor in a containment system and then either coring or morcellating the tumor with a scalpel or some type of alternative power morcellation device. I think it's interesting to go back and look at the historical background of how we got to where we are today. And my memory, which might differ from other people's memory, is that during the 1970s, we tended to remove uterine tumors intact, either through abdominal incisions that were sufficiently large to remove the tumor, or vaginal incisions for smaller uterine tumors. But then with the advent of laparoscopic-assisted vaginal hysterectomy and laparoscopic total hysterectomy, we began to develop techniques to perform hysterectomy through minimally invasive laparoscopic incisions. And this led, in the end, to advancing our skills with coring and morcellation. This developed rapidly during the 2000s, and with the advent of effective power morcellations, became a very common procedure. And then, of course, over the past few years, we've begun to realize that as we approach larger uterine tumors, we are having an increased recognition that occult cancers can be present in the tumor and that open power morcellation may have adverse consequences for the patient by spreading the tumor. And this has led to a careful review by gynecologists and regulatory bodies about how are we going to proceed in the future. I think in the future, as I mentioned, we will be approaching this issue in two major ways. We will either be attempting to remove the uterus and the uterine tumors intact, or we will be placing the uterus or uterine tumors in a containment system prior to either morcellation or coring with a scalpel or with a power morcellation system. I think these two approaches will have the greatest chance of improving the outcomes of this surgery. To put it in a little bit of perspective, if Dr. Wright, who is a member of the roundtable, estimate is that about 1 in 370 uterine surgeries are associated with the discovery of an occult tumor, what this means is that 99.9% the time, it would be safe to morcellate a uterine tumor, but we probably need to strive to reach 99.99% in avoiding the presence of an occult uterine tumor at the time that we remove the tumor with morcellation. In a related article, Dr. Scott Beast and Dr. David Mutch provide their approach to laparoscopic dual-port contained power morcellation. A key aspect of this approach is that all of the uteri and uterine tumors are placed into a containment system prior to power morcellation. This should, theoretically, reduce the chance of spreading small bits of tissue around the peritoneal cavity and allow us to remove large uterine tumors through small incisions. The detailed presentation should help guide surgeons to develop their own technique to this contained morcellation surgery. As noted by Dr. Beast and Dr. Mutch, an alternative is to perform contained power morcellation through a single port that is somewhat larger than the typical dual-port laparoscopic hysterectomy surgical approach. Dr. Shibley, an innovator in gynecologic surgery, has advocated and is developing technology to facilitate the single-port power morcellation technique. I urge you to look at the video presentation of this technique using the QR code that's present in the September issue of OBG Management. Finally, I'd like to talk briefly about a very important article by Dr. Henry Lerner, which provides a summary of the new American College of Obstetricians and Gynecologists report on neonatal brachial plexus palsy. The ACOG report is over 100 pages in length and densely referenced. Dr. Lerner, an international expert on brachial plexus injury and shoulder dystocia, has provided a concise review of this major publication. Some of the most important points provided by Dr. Lerner are that it's not possible to predict the occurrence of a shoulder dystocia. Consequently, clinicians need to be on alert for this obstetrical problem and be prepared to deal with it in a sequence of interventions. Another very important point made by Dr. Lerner is that shoulder dystocia is not necessarily always caused by so-called excessive traction on the fetal head. Dr. Lerner and the ACOG publication point out that neonatal brachial plexus palsies can occur in the absence of shoulder dystocia due to the forces of labor and the impaction of the fetus against maternal bony parts. Shoulder dystocia, from my perspective, is one of the most important and challenging problems we have in obstetrics. When we are on labor and delivery, we are hoping for the best outcomes for our patients, and shoulder dystocia only occurs in about 1 in 100 vaginal deliveries. Nevertheless, although it occurs infrequently, we need to be prepared for when it occurs. I think this is not dissimilar to pilots who fly commercial airlines. They know that very rarely there's going to be a significant problem on a flight, such as sudden loss of altitude, or wind shear forces, or loss of engine power, or famously having lost all engines due to bird strikes on your aircraft. And pilots practice their responses to emergency situations in flight simulators. Similarly, I think we need to continually visualize and practice our standard approaches to resolving shoulder dystocias in the most effective manner. Now, on a secondary point, I'd like to briefly talk about the issue of the medical record. When I have a shoulder dystocia, I go to the internet and print out the American College of Obstetricians and Gynecologists checklist for medical record documentation of a shoulder dystocia event. This is a 2-page checklist that contains, when it's completed, the most important information about the shoulder dystocia event. I then complete the checklist and dictate an operative note following the data entries that I've made in the checklist so that it can become a permanent part of the medical record. One area of particular controversy is whether we should use the phrase traction in our medical record. I'm a proponent of sunsetting the use of the word traction in the obstetrical record and replacing it with gentle downward guidance. My rationale for this is that when the obstetrician uses the word traction in the medical record of a shoulder dystocia delivery, that the pediatrician and the pediatric orthopedic surgeons and neurologists might put in their record the phrase that excessive traction was used by the obstetrician. Although the obstetrician has not used excessive traction, by having put traction in their record, the plaintiff's attorneys often say, well, you can see from the pediatric notes that excessive traction was used, and the word traction is in the obstetrician's note. So my advice is to replace the use of traction with the phrase gentle downward guidance of the fetal head. Alternatively, it might be good to modify the word traction by always using the phrase gentle traction.